Good morning. Today's topic is on localized aggressive periodontitis. So, this is an important topic. So, coming to the definition of aggressive periodontitis. Aggressive periodontitis is featured by rapid loss of periodontal attachment and tooth supporting bone, and it occurs in otherwise healthy patients. So, coming to the history of aggressive periodontitis. In 1923, Gottlieb described this disease as diffuse atrophy of alveolar bone. In 1928, Gottlieb again described this disease as deep cementopathia. In 1938, Van der Magner described that this disease occurs in incisors and first molars and called this disease as Periodontitis marginalis progressiva. And many others later described this disease as periodontosis. And it was in 1966 World Workshop in Periodontics. It was described that these diseases mainly occurs in adolescents and young adults. And in 1969, Butler described the term juvenile periodontitis. And in 1979, the disease was described as a disease of the periodontium occurring in otherwise healthy adolescents, and it is characterized by rapid loss of alveolar bone and it occurs in more than one tooth of the permanent dentition, and the amount of destruction is manifested and it does not commensurate with the amount of local irritants. And in 1989, the World Workshop in Clinical Periodontics characterized these diseases as localized juvenile periodontitis, and it was characterized as a subset of the broad classification of early onset periodontitis. In 1999, the World Workshop in Periodontics coined the term aggressive periodontitis, and several rapidly progressing periodontitis forms were united under the term aggressive periodontitis. So, this concludes the historical background of aggressive periodontitis. Now, coming to the classification and clinical characteristics of aggressive periodontitis. So, there are 3 primary features and 5 secondary features. The primary features are rapid loss of clinical attachment and tooth supporting bone, and the subject is otherwise healthy. That means the subject will not be suffering from any systemic disease or condition that could be responsible for the present periodontitis, and the presence of familial aggregation will be there. Coming to the secondary features, there will be inconsistency of the low amounts of present etiological factors, that is plaque, and the observed pronounced tissue destruction. There will be strong colonization by the Aggregation-Bacter actinomycetum comitans, that is AA comitans, and in some population there will be presence of Porphyromonas gingivalis. Immunological differences that do not entail the diagnosis of periodontitis, there will be immunological problems will be there, that is hyperresponsive macrophages and abnormalities of neutrophil functions. And the fifth feature, that is secondary feature, is self-limiting disease. So these are the secondary features of aggressive periodontitis. Coming to the diagnostic criteria to distinguish chronic and aggressive periodontitis. Coming to the rate of progression, aggressive periodontitis is a rapidly progressing periodontitis, while chronic periodontitis is a slow but rapidly progressing, progressing periodontitis, but rapid episodes are also possible in case of chronic periodontitis. Coming to familial aggregation, it is a typical feature of aggressive periodontitis. In case of chronic periodontitis, familial aggregation can be present in chronic periodontitis, but it is not a typical feature. Coming to the presence of etiological factors like plaque and calculus, it is often minimal in case of aggressive periodontitis, but in case of chronic periodontitis, it often commensurate with the observed periodontal destruction. Age, aggressive periodontitis often occur in young patients, that is in less than 35 years of old. And chronic periodontitis usually occur in older patients, that is more than 55 years of old. Clinical inflammation signs is often lacking in aggressive periodontitis patients, mainly in localized aggressive periodontitis patients. And in chronic periodontitis patients, the clinical inflammation signs commensurate with the amount of etiological factors present. So, in aggressive periodontitis, the rate of progression is rapid and familial aggregation is a typical feature. The presence of etiological factors is often minimal. Age, it occurs in often in young patients, and clinical inflammation signs are often lacking. Coming to the classification, that is subgroup classification. It is classified into localized and generalized forms. There are two thoughts behind this classification. One is that due to the robust response against the pathogen, the disease get limited only to certain amount of teeth. That is the one thought behind the development of localized aggressive periodontitis. Another thought is that localized aggressive periodontitis is a disease entity by itself with its own molecular and cellular mechanism. So these are the two thoughts behind the classification of aggressive periodontitis into localized and generalized forms. Now coming to the difference between localized aggressive periodontitis and generalized aggressive periodontitis. First one is regarding the age of onset. Localized aggressive periodontitis, the age of onset is around the circumpubertal period. And generalized aggressive periodontitis usually occurs in patients above 30 or less than 30 years of age, but it also can occur in older individuals. Regarding the serum antibody response, it is robust in localized aggressive periodontitis patients and it is poor in generalized aggressive periodontitis patients. Destructive pattern, in case of localized aggressive periodontitis, it is localized attachment loss at incisors and first molars, interproximal attachment loss at two or more permanent teeth, one of which is a first molar, and involvement of two or fewer teeth other than the first molars and incisors. When coming to the generalized aggressive periodontitis, there is generalized interproximal attachment loss at three or more permanent teeth other than the first molars and incisors. And in case of generalized aggressive periodontitis, there is episodic nature of attachment loss, which is not present in case of localized aggressive periodontitis. So, in case of localized aggressive periodontitis, the age of onset is circumpubertal and it has serum antibody response which is robust in nature, and the destructive pattern we have to always remember that there is involvement of molars and incisors, first molars and incisors, and involvement of two or fewer teeth other than the first molars and incisors. Now coming to the localized aggressive periodontitis, it is usually found in younger individuals compared to that of generalized aggressive periodontitis, and it is characterized as having localized first molar and incisor presentation with interproximal attachment loss on at least two permanent teeth, one of which is a first molar, and involving no more than two teeth other than first molars and incisors. Coming to the etiology, the main etiological agent is Aggregatibacter actinomycetum comitans or AA comitans, and in some populations, small amount of Porphyromonas gingivalis is also being detected. So, what are the features of AA which makes it responsible for the main causative agent of AA aggregative as a main causative agent of aggressive periodontitis? So AA is seen less frequently in periodontally healthy individuals, and AA produces leukotoxins that is capable of translocating across epithelial membranes, and it can induce disease in experimental elements. The leukotoxin destroys polymorphonuclear neutrophils and macrophages, which are the defense cells of our body. And the elevated levels of serum antibodies to This AA commitants was seen in diseased individuals, and also they produce antibodies locally against these organisms at the disease site. And the subgingival load of AA cannot be reduced just after the non-surgical therapy because they are tissue invading organisms. And the virulence of AA committance is variable, and different serotypes of AA, namely A, B, C, D, are present. Okay, and AA secretes membrane vesicles. They can serve as transport vehicles to spread the endotoxin and pathogenic substances produced by the bacteria. The lipopolysaccharide will activate the host cells, macrophages, and thereby secreting inflammatory mediators such as prostaglandins, interleukin 1 beta, and tumor necrosis factor alpha. This AA has properties like immunosuppressive activity. They are collagenolytic and they inhibits the neutrophil chemotaxis. Organisms associated with the localized aggressive periodontitis and generalized aggressive periodontitis other than AA are P. gingivalis and Tarnella forsythia. These organisms produce collagenases and proteases and endotoxins. These the local inflammatory responses are characterized by high levels of prostaglandin E2, interleukin 1 alpha and 1 beta. And the high levels of these inflammatory agents are seen in the GCF and also in the tissue. The specific antibodies against the aggressive periodontitis are associated with these microorganisms. And also we can see a depressed T helper to T suppressor ratio. Another etiologic agent associated with the aggressive periodontitis is smoking. So, how does the lesion get localized? So, 4 theories have been proposed. One is that after initial attack, there is adequate immune defenses are stimulated to produce opsonic antibodies that enhance the clearance of the invading bacteria. Okay, so the first teeth to colonize, first teeth to erupt into oral cavity, as we know, are the first molars and incisors. So the AA committants will evade the host defenses by various mechanisms and initiate the destruction of the periodontal tissue around these teeth. So after this initial attack, the immune defenses are stimulated and antibodies are produced and they enhance the clearance of this bacteria. So other teeth which erupt later into the oral cavity are not attacked by these bacteria. So this is the first theory. Second theory is that bacteria antagonist to the AA may colonize the periodontal tissue and inhibit it from further colonization. The third theory is that for unknown reasons, AA may lose its leukotoxin producing ability. Fourth is that a defect in the cementum formation may be responsible for the localization of the lesions. Coming to the prevalence and radiographic findings of localized aggressive periodontitis, prevalence is about 4.3%. Coming to the gender differences, some studies have shown that high prevalence is seen among black males, followed in descending order by black females, and white males. Some other studies have shown that there is no gender difference. Radiographic features, vertical loss of alveolar bone is noted around the first molars and incisors, and it begins in about the puberty age and in otherwise healthy teenagers. The classic radiographic feature is the arc-shaped loss of alveolar bone, and it extends from the distal surface of second premolar to the mesial surface of second molar. And the bone defects seen are usually wider than those seen in the chronic periodontitis. Coming to the pathology and risk factors, microbiology and host response to the bacterial challenge. Microbiology, as we have already discussed, the main microbiologic agent is the AA committants and the serotypes A, B, and C. Coming to the host response, the strong activation of the natural killer cells and natural killer T cells in patients with AA aggressive aggressive periodontitis was suggested to the causative for this enhanced tissue destruction. And we have also seen that the immune response will be decreased, that due to decreased function of neutrophils, that is their chemotaxis will be impaired, phagocytosis, and thus the killing of bacteria will be affected. Coming to genetics, familial aggregation is seen in aggressive periodontitis, and it is a typical feature, and autosomal dominant inheritance pattern is seen. Coming to the nucleotide polymorphism, single nucleotide polymorphisms have been proposed by various studies in genes that is coding for various cytokines such as interleukin 1 alpha, 1 beta, interleukin 6. But more studies are needed in this area. Coming to the environmental factors, studies have shown that people who smoke are more affected with aggressive periodontitis, or they have a greater loss of clinical attachment than non-smoking patients. Coming to the diagnosis, for this careful periodontal probing is needed, and we have to carefully assess the presence of primary and secondary features. And we have to send the patient for the consultation of a primary care physician to rule out the presence of any underlying systemic illness or conditions. And we have to take the radiograph for confirming the diagnosis and clinical findings. Coming to the management, after if we do the early diagnosis and intervention, we can prevent the disease and we can reduce the tissue destruction. Conventional periodontal therapy. So we have to start with the conventional periodontal therapy. It consists of patient education, oral hygiene improvement, along with scaling and root planing. If deep periodontal pockets with bone loss is present, we can plan for surgery. Surgery can be either resective or regenerative, or a combination of these procedures. So whether we have to go for resective or regenerative, we have to decide based upon the case, and we have to evaluate the risk and benefits of each case. If the case has severe horizontal bone loss, and if we go for resective therapy, it will increase the bone loss and it can lead to increased tooth mobility, and such tooth mobility will be difficult to manage. So it is in such cases it is better to avoid resective surgeries. And coming to regenerative therapy, the use of regenerative materials including bone graft and barrier membranes and wound healing agents are well documented. So if there is a presence of 3-wall defect where we can use the bone graft and barrier membrane, we have to go for that, so that we can regenerate the lost bone. Okay. So coming to antimicrobial therapy, we know aggregative bacter, actinomycetum committens are tissue invading pathogens. So we have to use systemic antibiotics. They would help to eliminate the tissue invading pathogens. So we can use systemic tetracycline, 250 milligram tetracycline hydrochloride 4 times daily for at least 1 week. And it should be given in conjunction with local mechanical therapy. Or we can give doxycycline 100 milligram per day. In case of tetracycline resistant species, we can use an antibiotic combination like mox and metronidazole. So before we prescribe any antibiotic, it is always better to go for an microbial testing and identify the bacteria present and select the antibiotic according to the type of bacteria present. Okay. So AA committens, the antibiotic of choice is metromox combination or metronidazole ciprofloxacin combination, or we can go for tetracycline. Another method is the local drug delivery. The primary advantage of local drug delivery is that we can produce or present a small total dosage of topical agents, and it can be delivered inside the pocket and we can avoid the side effects of systemic antibacterial agents. And we can also increase the exposure of target microorganisms to higher concentrations, and therefore more therapeutic levels of medication can be achieved. Local drug delivery agents and we can present the drug in the different forms into the target site, like solutions, gels, fibers, and chips. Another concept is the full mouth disinfection. It was put forward by Curie et al. And it consists of, the concept is that we have to remove all the plaque and calculus from the mouth, and this is completed in 2 appointments within a 24-hour period. In addition to scaling and root planing, tongue is brushed with a 1% chlorhexidine gel for 1 minute. Mouth is rinsed with 0.2% chlorhexidine solution for 2 minutes, and the pockets are irrigated with 1% chlorhexidine solution. Another method is the host modulation therapy, or host modulation, using host modulation agents. It's a novel approach in treatment of aggressive periodontitis. Here we try to control the periodontal disease by the administration of host modulation agents, and we try to modulate the host response. The most common agent, or the FDA approved agent, is the Periostat, that is low dose doxycycline hycalate 20 milligram BD for 9 months, and it decreases the matrix metalloproteases production. And if the teeth are in a hopeless prognosis, and we have to go for extraction, and then we have to do the prosthetic rehabilitation, either using removable partial denture, fixed partial dentures, or we can go for implants after careful planning. After periodontal therapy or after active therapy, we have to put the patient in maintenance, supportive periodontal treatment. Frequent maintenance visit appear to be one of the most important factors in the control of disease and the success of treatment in patients with aggressive periodontitis. And the duration between these recall visits is usually short during the first period after the patients complete the therapy, and it should not be no longer than 3 months interval. So to conclude, aggressive periodontitis generally affects systemically healthy individuals less than 30 years of age, and it is usually distinguished from chronic periodontitis by the age of onset, the rapid rate of progression, nature and composition of microflora, alteration in the host immune response, and familial aggregation of the diseased individuals. Aggressive periodontitis is classified as localized and generalized forms. And localized aggressive periodontitis is characterized by having localized first molar and incisor presentation with interproximal attachment loss on at least 2 permanent teeth, one of which is a first molar and involving no more than 2 teeth other than first molars and incisors. A comitans is the major organism seen in aggressive periodontitis, and radiographically the classic feature is the presence of arc-shaped bone loss extending from the distal surface of the second premolar to the mesial surface of the second molar. Coming to the management, start with the conventional periodontal therapy, that is scaling and root planing, or if there are presence of deep pockets and bone loss, we can go for surgical treatment, that is either resective or regenerative based on the risk-benefit ratio, or other treatments available are antimicrobial therapy, local drug delivery, host modulation therapy, full mouth disinfection treatment, and if the teeth present are in a hopeless stage, we can go for extraction followed by replacement of missing teeth. After the treatment, the patient should be kept in a regular maintenance treatment. Thank you for your time and support.